I'm just starting with a brief disclaimer that anything crazy I say is not from Thermo Fisher, it's from myself, and I'll just blame my parents for that one. So this is a picture of our clinic. So we are from Victory Reproductive Care. My name is Dr. Adam Pillon, and we are a leader in Canadian reproductive health services. So we are located in Windsor, Ontario, which is right across from Detroit, Michigan, right across the border. So because of our geographical location, we offer a very extensive third-party program for international patients, whether that be from America or any other place around the world. And we like to say that we provide patient-centric or patient-specific fertility management, and I know a lot of clinics do say that. But at Victory Reproductive Care, we do take a lot of these cases a step further by doing things like microbiome testing, immune cell testing, and immune genetics. So we try to make it as specific as we can to our patients to ensure that we have outcomes for possibly patients who couldn't get them before. We are now offering in-house PGT thanks to our partnership with Thermo Fisher Scientific. So if anyone has any questions about that, feel free to ask me after the talk, or my email will be available at the end of the talk. So up here, this is Dr. Rahi Victory, who couldn't be here today. He is our fearless leader. He is the medical director of Victory Reproductive Care, and the reason we're all able to do what we do up in Windsor. So now to get into our actual talk. So I'm going to be talking today about evaluating the viability of non-2PN embryos with the advancements in preimplantation genetic testing. So what does that really mean? So the idea is, what do we do with non-2PN zygotes? So when we're talking about non-2PN, the idea is we should have paternal DNA and maternal DNA, each forming a pronucleus and coming together so that we have diploid embryos. But that doesn't always happen, as I'm sure we've all seen in our clinics or in our laboratories. So the idea is, what are we doing with them? Because currently, most places are discarding them. So we looked at a review of the literature for both the laboratory and clinical lens, because I think the idea of this two-pronged approach, or this two-lens approach to address a problem, is what we need to do going forward. Because a lot of times in reproductive medicine, I think we're siloing information. You know, the lab is trying to solve one problem, the clinic is trying to solve another problem. But I think going forward in reproductive medicine, it's really important to ensure that both the lab and the clinic are working together to solve problems like this. And so the first lens is the clinical challenges. You know, what is going on and why are we looking at this? So about 10% of fertilized oocytes will display abnormal PN numbers. So again, abnormal pronuclei number, meaning 0, 1, 2.1, 3, or higher PNs when we check at fertilization. And historically, these non-2PNs are discarded. They're just thrown away because we're seen as abnormal and cannot be used for transfers. But what this does is we are reducing the number of embryos available for poor prognosis patients, right? Some patients, these are their only options. This is the only thing that develops for them. Or we have patients who maybe don't have their intended family number yet, and we're throwing away embryos that could be entirely effective for frozen embryo transfers. Also, for our healthy prognosis patients, again, we might not be reaching their total number of intended family members yet, and forcing these patients to go through another round of retrievals, which, as we all know, isn't necessarily the best thing for the patient in every case. So could these embryos be used safely following genetic testing, now that we have the ability to detect ploidy number in our PGT-A samples? So traditionally, what's happening is we have superovulation, oocyte retrieval, IVF-ICSI, then we do a FERT check. So 16 to 18 or 20 hours later, we check how many pronuclei they have. And we have two options. 2PNs we keep, non-2PNs we discard. But the limitation with that is that that's a morphological trait, right? So if we think about that, a PN is a morphological trait, but we are making a genetic diagnosis based on a morphological trait. And this is where I want to start shifting our mindsets and kind of opening our ideas, because if we think about 2PNs, right? We've all seen 2PNs, they come back, we do PGT-A, it's polyploid. Well, if a 2PN can be polyploid, how come a non-2PN can't be diploid? If we're accepting that 2PNs can be abnormal, we must accept that non-2PNs can also be normal. And there's clinical evidence to support this. So in 2017, there was a very large study done with about 500 women. There was 719 PGT-A cycles done in over 5,000 mature oocytes. And they found that about 5% of those were 1PNs, less than 1% were 2.1PNs. And they actually achieved 3 live births when they tested these for diploid rates. 1 was from a 1PN, 2 from 2.1PNs. And when they looked at the entire study, by including these, they actually got an increase in their live birth rate. 7.2 or 17.2 to 17.7 obviously isn't a huge jump, but 0.5% is still an increase in live birth rates. And I think that's why we're all here, right? We're trying to increase our clinic's live birth rates. And by including these embryos, they were able to do that because once they had determined they were genetically normal, they were performing very similarly compared to their 2PN counterparts. This Al-Hashimi study, you'll see me reference a couple times. So in 2025, they looked at a large cohort of PGT-A tested embryos. And what they found was 80% of the non-2PNs were actually diploid tested at PGT-A. So if we think about that as, say for your clinic, you had 1,000 embryos that were non-2PN that you discarded. You threw away 800 embryos that were diploid, which at that point, they are at the same stage as a patient who perhaps didn't opt for PGT-A and had a 2PN that wasn't genetically tested. At that point, we assumed that was diploid, but because of a morphological decision, we decided that those 80% or those 800 embryos should be discarded. So we took 800 embryos out of the options for patients to make autonomous decisions about their care. And in 2014, they looked at 0PNs and 2PNs, and some 1PNs, and they found that between 0 and 2PNs, there was really no difference in blastulation. So if we continued culturing these non-2PN zygotes, they reached blastocyst stage almost exactly the same way as 2PNs did. The 1PNs kind of weren't quite as good as the other ones. However, they were still viable. There were still viable options in that population. So the idea is, again, we were getting rid of options for patients that not just genetically look okay, but in terms of blastulation, looked perfectly fine. So the clinical message here is that we need to incorporate genetic testing into the workflow to allow for safe inclusion of previously discarded embryos. Because I'm not up here promoting the idea that we just put in non-2PNs, we let them culture, and we treat them like 2PNs. Because the idea is, yes, they are still likely to not be diploid. They still have that chance, probably a little bit more than when we're looking at 2PNs. But because we have the ability to test for diploidy, if we include that test in our workflow, we don't have to discard these embryos. And so if we want to look at the data in kind of a more easy to digest format, all of these things on the left, these are just the references that are included in this graph, and we kind of plotted them. So if you look at the green or the far right bar in all 3 of these cases, these are diploid rates. So 2PNs reached a diploid rate of 90%. So again, I'm going to propose the idea that we open our minds because everyone said a 2PN, that should be diploid. However, 10% of them weren't. So that means that non-2PNs, in my mind, could also be diploid. And that's exactly what we saw. So if we look at 0PNs, 76% or around 80% of them showed to be diploid. 1PNs, a little bit lower. Like I said, these 1PNs seem to act a little bit abnormal still, but there's 70% of them reaching diploid rates. Then we go for the heavy hitter, what everybody wants, the blue graph, the live birth rates. So if we look at that, 62% in 2PNs and 59% in 0PNs. So when we looked at live birth rate, there was almost no difference between a 0PN that was tested for diploidy and a 2PN that was tested for diploidy. When we put those in, we still get the same live birth rates. Implantation rate, we see the same thing, 55% in the 2PN cohort and 48% in the 0PN cohort, suggesting again that these 0PNs and 2PNs are functioning pretty close to each other. And yeah, we are getting some decrease in the 1PN group. However, 30% implantation rate or even 40% live birth rate is not 0. So the idea before that we were discarding these embryos based on a morphological decision, however, we probably could have got a live birth rate. Again, if we go back to that example of we had 800 embryos that we had all discarded, 40% of those, even if they were all 1PNs, 40% of those could have turned into live births. So I think that's where we have to, again, kind of keep opening our minds and see that maybe we were creating a bias on our own from previously unknown information, right? We didn't have this access before to this ploidy testing that we do now and how affordable it can actually be. So we were making this criteria that we were kind of stopping ourselves and kind of creating this barrier that maybe doesn't exist in the natural world. And when we look at it from a laboratory rationale, these are the people we're actually doing the fertilization checks. We're in the lab, we see what happens, the PN number is identified. But again, that's morphological. We're saying we saw 2 pronuclei or we didn't see 2 pronuclei. And then from that decision, for some reason, we're saying, well, that must mean that's going to equally to tell us what's going on genetically. But we know that isn't the case. And again, I'll kind of propose this idea, right? We've all seen in the clinic, we all grade maybe a little bit differently, depending on where we're from. But we grade our embryos how they look, right? So if we have a top graded embryo, we send it for PGT-A testing, we're like, this is gonna come back great. It comes back aneuploid. And then we have that really poorly graded embryo that we're like, there's no way this is okay, and it comes back euploid. So that's another instance where we're making genetic decisions or we're assuming genetic decisions based on morphological traits, which again means that we're throwing away or ruining chances for people to have extra options for autonomous choice. And that's where we have this genetic assessment involved in our workflow because we can accurately determine the viability because we all know, it has to be diploid and it should be euploid, right? That's our best option. And we're able to find that out now. And so from the lab perspective, it's very good to understand what's going on and how we can get these different amounts of ploidy. So when we talk about heteroparental diploidy, obviously that's what we want. We want 1 copy from maternal, 1 copy from paternal. We get an embryo that has 1 of both, and it's diploid. In haploidy cases, we have 2 options, right? One comes from, you have 1 copy from the maternal source and no copy from the paternal source, or vice versa, where you have 1 copy from the paternal source and no copies from the maternal source. Triploidy or subsequent polyploidies are kind of a different situation, right? Where you're getting too much information from one of the gamete sources. So either too much from the female or too much from the male, and you end up with too much DNA. But this last one is what gives us a little bit of interesting idea when we're doing our PGT-A testing. So uniparental diploidy is also possible, where we have too much information or 2 copies from a maternal source and no copies from a paternal source, or 2 copies from a paternal source and none from a maternal source. So the reason this is important is because normal PGT-A is looking for something called copy number variation. So you're just saying, how many copies of something that I looked at do I see? It's kind of like a counting assay. So if you see 2 copies, that's great. We're assuming it's diploid. However, we need to ensure that it's heteroparental. So in order to do that, we need to be using some new technology where we're looking at SNPs or SNPs. So what we would do is we trace the SNPs back between the embryo and the parent to ensure that we're seeing 1 copy from maternal and 1 copy from paternal. So this idea is, I am proposing we're using PGT-A, but when I say that, I mean PGT-A plus ploidy. We need to be doing some extra steps to ensure that we're getting the most accurate information for using these embryos that were typically discarded based on guidelines from our embryo training colleagues. So I'll talk a little bit about our kind of more common situations. So the first one is a 1PN. So a 1PN, as you can see, 1 circle inside of the middle. That's what we have when we have a 1PN. But from the literature, it suggests that 1PNs are actually a little bit larger than when we have 2PNs. So this could suggest maybe the reason we're remaining diploid is it's able to have all of the DNA in one pronucleus, whether that's from the other pronuclei not developing properly or we're getting it segregating improperly. Whatever the case, we're still ending up with diploids in 1PN. And when we looked at these cases, about 50% of the monopronuclear IVF cases had both maternal and paternal DNA present in a single PN. So again, we're getting that heteroparental diploidy like we looked at from 50%. So you saw the stats before were about 70, so we did lose some along the way. They didn't quite make it, but we're still looking at 50%. So going back to that idea of maybe we had 800 1PNs, we discarded 400 embryos that were in the same category as an untested 2PN. which to me is a little bit shocking. And when we saw this, it was like, oh my goodness, what are we doing? So that's why we're proposing this change. Another one that's quite common is the 2.1 PN zygotes. So what that means is you have two pronuclei forming, and then you have this little tiny bit called a micronucleus that I think you can see quite well on the C, in the C image, right, kind of between the two on the upper left-hand side. So what that's doing is there were these options of what's happening. The first thought was we have two pronuclei, meaning we have parental DNA from both parents, and we have some extra DNA. So the theory was this will be over the diploid amount. However, when we use PGT-A to recommend to confirm viability, we're finding that maybe that's not quite the case. So the idea could be perhaps there was an issue with segregation and there was remaining DNA outside and a micronucleus formed to protect that DNA. Or a micronucleus formed for no reason. We're not really sure what's happening, but when we look at that Al-Hashimi study that I referenced earlier, 24 out of 24 2.1 PN embryos ended up being diploid. So that's 100% of them retained the right amount of DNA, even in the presence of a micronucleus, suggesting that maybe we were wrong about this housing some extra DNA material. And I mentioned we were going to talk about euploid rates a little bit later, and this is where we're at. So the Al-Hashimi study looked at which ones made diploid. That's the first column there. The second column is who made it to being euploid. If we look at, say, the 2.1 group, like I said, 100%, that was 24 out of 24, made it to the diploid stage. And when we look at euploid, we got 8, about 33%. If you look down at the 2PN rate, we saw about the same thing, about 35%. Now, obviously, these numbers are quite small when we're talking about non-2PNs because they are quite rare. And so obviously we need more information, but even when we're looking at the total non-2PNs that were identified to be diploid, about 40% of them ended up being euploid. So again, I do think that number might be skewed a little bit high because of our low sample size that was available, and it might be very close to our normal 2PN rate, which is around 35%, right? Because this wasn't stratified for age and anything like that. This was just everyone together, how many of them made it to a euploid diagnosis. And so I think this kind of speaks to, again, this idea that we need to open our minds. We need to say we have the data now that's showing that not only are these diploid, but a lot of them are actually euploid. They're reaching the same euploid rates that we're seeing in our 2PN counterparts. So why are we discarding them when we have every opportunity now to be doing this ploidy test and getting the same information? And so if we look at some more recent genetic findings, we're looking in the 2017 study where we have about 69% of 1PNs ended up being diploid, 86% of the 2.1s ended up being diploid. The McCallie study had even more patients in that study, and we saw the diploid rate around 56% for 0PNs and about 30% for the 1PNs. Like I said, the theme is that these 1PNs seem to be performing a little bit less optimally than we'd like compared to the 0PNs and the 2PNs. However, they're not zero. We all have patients where maybe you're getting a 0PN or you're getting 2PNs that also just aren't looking that good. So I think they're being put in the same category at this point based on the data we're seeing here. And when we look at the implantation rates in a 2024 study that I presented before, again, similar implantation rates between 0PNs and 2PNs. So when we look at outcomes, not just genetics, we're seeing the same thing. And then if you want to talk about morphology, the 2.1 PNs, if we allowed them to culture to reach blastocyst stage, they were performing the same level as the 2PNs in morphology grading. Meaning when we looked at 2PNs at day 5 and 2.1 PNs at day 5, there was almost no difference. They actually in the study couldn't tell the difference between the two until they unblinded what they saw. The implication here is that the significant proportion of these morphologically abnormal embryos are chromosomally normal, and therefore, in my opinion, being put in the same category as our 2PN patients who aren't opting for PGT-A testing. So again, I want to bring this idea home of our laboratory workflow before was discarding non-2PNs because they looked kind of funny. I would propose the idea. I know people who look kind of funny, but are perfectly normal on the inside, so maybe we should give our embryos the same benefit of the doubt. Because again, I believe, as someone who runs our PGT-A program, I see embryos all the time that are 2PNs, they come out, they're polyploid. Okay, well that makes sense, that happens sometimes. But then I've never kind of shifted my idea to, well, the non-2PNs then might be diploid the whole time. And so we need to shift to this new idea where we're culturing all of our PN types, regardless of what we see, and then we're using this PGT-A test for ploidy, where at the same time we're determining, are you diploid and are you euploid? So I think in that case, we're getting all of the information all at once, and we're able to counsel these patients more effectively. Because then the outcome is we have safe rescue of viable embryos and improved embryo utilization rates, right? This might be adding 2-3 embryos to some of these really tough cases of patients who perhaps have a meiotic condition or a mitotic condition where we're getting abnormal PN numbers that aren't actually reflecting the ploidy of the embryo. And there's even more technology coming day by day that's allowing this to be a little bit easier. When we talk about AI, there's now AI programs that use time-lapse imaging to look at the pronuclear formation in zygotes and give you kind of a score. It says, did it look like it formed properly? Did it look like they're fusing properly? All of these things. It gives you an idea. And when you look at the cost analysis on that, it actually doesn't add that much to the workflow. So integrating something like this could even remove the bias that might be seen in a human eye looking at the embryo and deciding the PN number at a specific time. Even when we talk about non-invasive techniques. So again, right now we're talking about using an extra test to determine what embryos are viable, but there's even more tests coming out now. There's tests with spent media being used for genetic testing, and there's even spent media being used for metabolomic testing, where we're looking at the metabolites being released by these embryos that again could be possibly saving completely viable embryos that our previous ideas have allowed us to throw away. And that's why it's so important to come together as a clinical and laboratory team. Because from the clinical side, if we change our ideas, right? Say I've convinced everyone in this room and we've changed our ideas, we're not throwing away non-2PNs anymore. Well, we need to have this conversation with our clinicians so that they can have this conversation with our patients. Because perhaps when they're counseling their patients and talking about selection criteria, perhaps the idea would be we're still ranking 2PNs higher than the non-2PNs, even if they end up euploid. That's up for a clinic to decide, but that's when we're doing single embryo transfers, people always have the question, why did you choose this one over that one, right? So we need to have that conversation of perhaps, previously we would have said that's not even an option, and now that it is an option, we might say something like, oh, well, we've decided that this one's gonna be graded a little bit lower because it didn't look entirely normal during its development. However, we have tested it now, and it does meet our criteria for transplant. Then from the laboratory side, that pronuclear assessment accuracy. Again, do we need to add AI? Do we need to change how many times we look at the PN? I don't know what that means, but I think it's the conversation around what are we doing to make sure we're looking at the most accurate information. Biopsy precision, that's always a problem, right? Are we getting accurate biopsies to the genetics lab so that they can give us accurate information? Do we need to have appropriate training? The PNs, do they biopsy the same? All of these questions we need to kind of answer, I think, as a group. And then the ploidy interpretation, right? Using those SNP values, not just our CNV values when we're doing genetic ploidy assessment to ensure that we're getting diploid, but we're getting heteroparental diploid. Because we want to make sure we're making this as robust as possible so that we can change our workflows. Old workflows being superovulation, ICSI, FERT check, throw the ones that we don't like away. The new one might be superovulation, ICSI, FERT check, culture everything, tell the patient we're doing PGT-A with ploidy, give them that option if we see a lot of non-2PNs, and then we transfer a balanced diploid regardless of what it looked like during fertilization. And so this would mean that we have increased embryo availability and improved outcomes. Like you saw in that 2017 study, not only did this improve selection for patients, it improved live birth rates, which is what everybody wants here. So that take-home message is, again, what I've been trying to change this whole time, is maybe we need to shift our mentality. We've been accepting for decades that 2PNs can be morphologically abnormal in terms of their grading and can have alternative ploidy numbers, regardless of what we see at the fertilization. So I think we need to accept that and remove the barrier for non-2PNs to say, we've looked at this, and we now know that just like 2PNs, their ploidy is not defined by their morphology. Their abnormal fertilization check does not make them non-viable, and morphology does not determine the destiny of this embryo. We have access to PGT-A ploidy testing now that could uncover these hidden embryos and determine if that's the patient's only option, and that could be the patient's only baby if that's what they wanted. And so that's where this collaboration between clinical and laboratory teams is key to advancing ART success, because it allows us to tackle this from two different avenues: the patient side and the clinician side, and the laboratory technical side. And I think that's where I'd like to end it today. And this is our references that I used during this talk. And I'd like to give a special thank you to Thermo Fisher Scientific for allowing us to have this talk, as well as a special thank you to Dr. Victory and Dr. Khosravi, who could not be here right now, but did a lot of work on this presentation with me. And I'd like to thank everyone here for listening. That is my email on the left and our clinic's email on the right for any questions, but I'd be willing to field some as well right now. Thank you.